Welcome to my podcast, Diet, Disease, and Doctor Dialogues. In this episode, you can listen to an interview with a sleep medicine specialist to learn about sleep apnea, symptoms, treatment and management, and related health effects. Stay tuned for the next 30 minutes to learn about the ins and outs of sleep apnea. Welcome, Dr. Seema, to Diet, Disease, and Doctor Dialogues. Thank you so much for being here today. Dr. Seema is a fellow of the American Academy of Sleep Medicine. Would you like to say a little bit about yourself?
Yes, first of all, Naomi, thank you very much for having me here today and for giving me the opportunity to speak about one of the most important aspects of and often under-recognized disease condition pathology. And thank you for bringing up the topic, thereby raising awareness. To tell you a little bit about myself, my name is Emmanuel Seema. I'm Ethiopian. I grew up in Ethiopia until I was about 14 years old. In 1984, I immigrated. My dad gave me the opportunity to come and study in the United States. So I took up that opportunity and I entered high school in a boarding school in Kentucky, about 80 miles south of Lexington. I had a great time there. It was a memorable time. When I finished high school, I enrolled at Berkeley, University of California at Berkeley. I studied human physiology, biology, and then proceeded to enter medical school at University of Southern California, USC. After completing my medical school studies, I entered. I was given the opportunity to enroll in a residency program at UCLA, the internal medicine program, internship and residency. It was an extremely rewarding, wonderful experience. One of the things I need to say is that, medical training, medical background matters a lot when it comes to becoming a well-rounded physician. And I'm not trying to pat myself on the back, but what I do want to say is that the exposure I was given to highly variable disease conditions and the experience of diagnosing them and treating them as an internist uh, was tremendous at UCLA. And so when I finished internal medicine residency there, I proceeded to do a fellowship in pulmonary critical care and sleep medicine, that is pulmonary lung specialty, treating lung diseases, critical care, that's being an ICU doc, running ventilators, life support machines, and so forth. And sleep medicine, sleep medicine is a relatively young field of internal medicine. And when they started it out a few decades ago, they sort of attached it to pulmonary. So pulmonary fellows are given the opportunity to specialize also to add that additional qualification as a sleep specialist. Typically, it's either a pulmonologist or a neurologist. Just by default, they kind of gravitated that way. Primarily because, as you know, one of the most common conditions in terms of sleep pathology is obstructive sleep apnea. That involves breathing abnormality, deoxygenation, problems with gas exchange, and lung mechanics. So I think by default, a lot of the pulmonary profession took up sleep medicine as an additional task, if you will. So when I finished, I married my college sweetheart, who's also an Ethiopian. I have three boys, three young men. One is in college; he's a second-year civil engineering student at University of San Diego. The other one is the middle one is in a senior, and then third one is in seventh grade. That kind of sums up my background, if you will.
Thank you for sharing that with us. And to start us off, could you start by explaining what obstructive sleep apnea is?
Okay, very good. So, two words: sleep apnea. So, the definition of apnea is basically it's a medical term that refers to the temporary cessation or the pause, breathing pause, where an individual stops breathing, basically. So apnea literally means to stop to breathe. So if you add sleep in the context of sleep apnea, it involves the repetitive stopping and starting of breathing difficulties during sleep, typically due to an obstruction in the airway, i.e., obstructive sleep apnea. And there's another term, central sleep apnea, where the breathing centers, the brain, the part of the brain that controls breathing stops working and patients stop having breaths. So sleep apnea means cessation of breathing during sleep.
So now that we understand what sleep apnea is, could you describe the standard methods used for its diagnosis?
Yes, so the standard method of diagnosing sleep apnea is through what we call sleep study, also known as polysomnography. Now, two terms: polysomnography. Somnolence means, or somnolence means to sleep, right? So polysomnography means, poly means multiple parameters, and graphy means to detect. So there's three words, as a matter of fact. Polysomnography, which means measurement of the different parameters of sleep. Basically, poly means many, right? So polysomnography means sleep study, whereby the brain waves, breathing, oxygenation, heart rate, muscle movement are all measured and monitored continuously. So the standard method of diagnosing sleep apnea is through what we call polysomnography. This test basically monitors, like I said, just to summarize, the various physiological parameters during sleep. Primarily, the brain EEG. Is the patient sleeping well? Do they have a good consolidated sleep, or do they have fragmentation of sleep? Eye movement. Are they in dream state, or are they in deep sleep, or are they in a wakeful state? Muscle activity, heart rate, oxygen levels, and breathing patterns. Another less intensive method is what we call home sleep apnea test, where patients use a portable device to measure similar parameters but more limited parameters to detect sleep apnea.
This makes me wonder, if a patient with a sleep apnea has a narrow airway, why does the airway collapse only during sleep?
Very good question. So let's go through the physiology of breathing. Okay. Typically, human beings, not typically, all the time, under normal conditions, you and I right now breathing, we breathe through what we call a negative pressure system. What that means is, as you know, basic science, air flows always from higher pressure to lower pressure, right? So if you want to create an airflow, what you do is you create a situation where you have either you can move that air by pushing it or by sucking it, right? By
Mhm.
pushing it or by sucking it. So literally, we suck air in. How do we do that? We create our diaphragm expands. We create a negative pressure in our lung. So air naturally goes from a higher pressure, meaning atmospheric pressure, to a negative pressure. So we suck air in, right? So then when we exhale, our diaphragm contracts, creates a positive pressure in our chest, within our chest cavity, and air is pushed out. We exhale, correct? So sleep apnea occurs due to two main factors. Sometimes people have collapsible airways. They're just naturally their upper airway, the airway through their throat is collapsible. And you may ask, okay, then why don't they have sleep apnea when they're awake? Because remember, when we are awake, our muscles are always tense. We keep posture, right? Right now, you're using literally hundreds of muscles to sit up. Our airway is continuously with muscle activity that keep the airway taut, firm. Okay. When we go to sleep, nature has it that it cuts off all input to muscles. Why? Because nature has it that we don't act out our dreams. So a sleep state is what we call a flaccid state. If you pick up the arm of a sleeping person, they're like deadlocked. They literally are paralyzed. Literally, they're paralyzed because the muscle, the neuronal, the nervous input from the brain into the muscles are cut off. Consequently, if someone has a collapsible airway, that muscle input, that muscle activity is gone, so the airway collapses. So when they create this negative pressure to breathe, the airway collapses. Thereby, they snore, and thereby they have sleep apnea. Now, those are a minority of patients. Now, a majority of patients with obstructive sleep apnea are with obesity, right? They're overweight. So as fat infiltrates, obesity just means excess fat tissue, right? It's in our belly, it's in our neck, it's in our back, it's in our arms, legs. Fat also infiltrates the airway and it makes it more collapsible. Thereby, the same physiology I just described to you happens. So the majority of patients with obstructive sleep apnea are obese.
You mentioned obesity. Weight management can be challenging for sleep apnea patients, as weight gain and sleep apnea often create a vicious cycle. Could you explain the cyclical relationship between obesity and sleep apnea?
Correct. Very good. Excellent question. So, obesity itself can cause obstructive sleep apnea through the same pathophysiology that I just described. Now, what is interesting is there's an additional layer of factor. When patients with obesity experience untreated sleep apnea, what also occurs is during these sleep apnea events, there are biochemical changes in our body that causes weight gain. I don't need to go into the minutia, into the details, but there are chemical changes during the stressful event of a sleep apnea, which occurs hundreds of times a night, cyclically, throughout the night as the patient sleeps or as the individual sleeps. So these biochemical changes, one of the consequences of these biochemical changes is weight gain. So these patients go into this vicious cycle. They gain weight, they have a more severe sleep apnea, they have a more severe sleep apnea, and therefore they gain weight and they go into this vicious cycle. And one of the major ways to address that, in addition to treating the sleep apnea and addressing the immediate issue of deoxygenation and gas exchange abnormalities and the consequence of those things, they need to enter an intensive weight loss program because when they lose weight now, and the reverse happens, less weight, less sleep apnea, less sleep apnea, less weight.
Building on what you mentioned about treating sleep apnea, what would be the most common treatments offered to sleep apnea patients?
So the most common, the most common way to treat obstructive sleep apnea is through what we call PAP, positive airway pressure, and most commonly CPAP, continuous positive airway pressure. Remember what we talked about, right? We breathe through a negative pressure system. Diaphragm expands, just to review. Negative pressure is created in our chest cavity, air is sucked in, right? And then in this case, when the patient's airway collapses and they have sleep apnea, now what we do is we give them PAP therapy, positive airway pressure. Remember, we breathe through negative pressure, right? Now we are pneumatically through a mask. We put a nasal mask or a nasal oral mask, nasal pillows, and different types of masks, different types of interface. We keep the airway pneumatically through pressure open throughout the breathing cycle, right? When the patient inhales now, they're breathing through a positive airway because the airway collapses. To keep that airway open, we're blowing pressure in. So when we do that, not only are we keeping blowing pressure, pressure also means airflow, right? So continuous. Remember, the airway now, instead of going positive, negative, positive, negative, positive, right? That's how we breathe, where negative pressure, you inhale, positive pressure, exhale. Now we have continuous positive airway pressure, where we, through pneumatically, through a positive pressure system, we keep the airway open so that the airway doesn't collapse and the airway is open and the patient is able to breathe.
I
That's the most common way of treating the patient. And there are different types of positive airway pressure: CPAP, BiPAP, bi-level therapy, auto CPAP. There are different types, but the basic concept is positive airway pressure to treat sleep apnea.
I was looking into CPAP and I found that the patient adherence rates were really low. Why is that?
Okay, so patient adherence to CPAP therapy is often low because imagine our brain, us, our consciousness, our subconscious is programmed to breathe through a negative pressure system, a pressure, positive pressure system. And all of a sudden, you're putting a mask on someone and you're blowing pressure and air. You're blowing air through a positive airway system. So even when they exhale, they're exhaling against a higher pressure, which means their work of breathing is a little bit more. And it's uncomfortable because the brain is confused now, seeing net positive pressure. So there's feeling of choking, uncomfortable, sort of suffocating. So it's a very uncomfortable situation. Well, one of the things they used to do during sleep fellowship is they used to have us wear this. And I have to tell you, it takes a lot of getting used to, and we have programs to get people, acclimated to using CPAP. But the discomfort of wearing the mask, the feeling of claustrophobia, noise from the machine, difficulty in maintaining a proper seal around the mask, and the inconvenience of using the device every night are big factors. So the adherence rate, unfortunately, is terribly, terribly low.
So, if a patient wants to do an alternative treatment to CPAP, what other treatment options would you recommend?
Okay, so for patients seeking alternative approach to CPAP, options include oral appliances. They're literally are braces that are applied like at night when you go to sleep. It thrusts the jaw forward, thereby opening the airway up a little bit more. Unfortunately, these devices, number one, can cause TMJ, jaw problem in the long term. Also, they can only be applied for mild sleep apnea. They're not effective in successfully treating moderate to severe sleep apnea. But oral appliances are devices that are custom fitted devices that adjust the position of the jaw and the tongue to keep the airway open. Other options include positional therapy, where we give patients these wedge pillows, where the patients are sleeping at a 30-degree position, 45-degree position, to reduce the chance of airway collapse due to gravity as the patient lies flat at night. Weight loss programs, but that takes a while, but they're also considered. And there are surgeries. Okay, now surgeries include what we call UPPP, uvulopalatoplasty, which basically we carve the airway because the airway is so dense and obstructed because of redundant tissue. We literally carve the airway. We open the airway up. So we call it UPPP. That's one. Also, some patients may also benefit from newer technologies such as adaptive servo ventilation, ASV. ASV. There is something called Inspire, where we actually put in devices to stimulate the hypoglossal nerve, one of the nerves that remember what we talked about, how the nervous system, when the brain, when we go to sleep, the nerves shut down so that we don't act out our dreams. So the muscles of that airway, the airway is affected, rendering it collapsible. We actually now have devices. They're called Inspired. So it's a patented product. It's out in the market now, where we put a device to stimulate that nerve to keep the airway open as we stimulate the muscles to keep to keep the airway rigid, and it helps in maintaining airway patency during sleep.
Since these surgical treatments you just described for sleep apnea are more invasive, What factors should a patient discuss with their physician to determine if surgery is the right option for them?
Very good. So surgery, it's not without its complications, obviously, from the simplest fact that people can bleed a lot, infections, and so forth. So patients should discuss several factors with their physician. And number one being the severity of their sleep apnea. So if they have mild sleep apnea, surgery is not an option. The risk benefit ratio just doesn't add up. The specific and not anatomical causes of their airway obstruction. It's are they a good candidate? Because some causes of sleep apnea, basically just simple weight loss can do the trick rather than going through an invasive surgery. Also, if they have a surgically correctable sleep apnea, are they a good candidate? Are their overall health, good enough? Are they suitable for the surgery itself? Uh, and then also, have there been other attempts, for instance, CPAP therapy, oral appliance, other therapeutic options that have been exhausted before they arrive at the idea of surgery for sleep apnea. Now, also, they need to talk about, surgical complications, bleeding, infection. Also, with the airway surgery, one can also end up having dysphagia, difficulty swallowing. When one of the main things, for instance, when people go through UPPP is when they drink water, it goes up through their into their nasal passage. They have difficulty swallowing even solid food. So as a consequence, as a complication of surgery. So they need to, so it's three things. Number one is, are they a suitable candidate? Number two, do they know all of the surgical complications that can come about? And number three is, have all other therapeutic options been exhausted?
While we're on the point of treatment, if disruptive sleep apnea is not treated, what are the potential long-term health risks for individuals with it?
Okay, so let's look at the physiological changes or abnormalities that occur during sleep apnea. So when someone goes through these cyclical cycles of cessation of breathing, oxygen saturation goes down, heart rate goes up, the brain is disturbed. So there's sleep fragmentation, there's no solid sleep. Number two, tissue stress. The brain and the heart, particularly the brain, is very sensitive to low oxygen levels. And all of these things are happening, and the patient is not aware of it because they're asleep. Okay? And imagine deoxygenation happening hundreds of times a night, causing brain stress, heart stress, and all the biochemical changes I talked about that cause obesity. So in the long term, the patients tend to have more and more progressively worsening obesity, and with that comes other issues such as diabetes, worsening sleep apnea. From the cardiovascular perspective, they can also end up having pulmonary hypertension. Pulmonary hypertension means there are pressure changes in our lungs that occur during deoxygenation. The lung is also stressed, and with these cyclical deoxygenation events that happen hundreds of times a night over several years, the blood vessels themselves remodel in the lungs. They narrow down, they become stiffer, and their blood pressure is up, pulmonary hypertension. And there's a whole slew of complications that come up with that, heart failure. Also, patients, there's a high risk of stroke, high risk of heart attacks. So it is not a condition that should be ignored because the consequences are vast and they're very serious.
Having discussed these risks, it's clear that treating sleep apnea can help prevent these complications. So, I wanted to dig a little deeper into the relationship between hypertension and sleep apnea. Could you describe a clinical scenario where uncontrolled blood pressure is linked to obstructive sleep apnea?
Yes. So absolutely. So that's one of the main things. The pulmonary hypertension I talked about also can occur, does occur, and actually it's more common, and even in the shorter term for untreated sleep apnea to be an independent cause of systemic hypertension. This is an often ignored and overlooked fact. I have had patients that come in for sleep consultations, and their blood pressure is severely uncontrolled. They're on multiple medications, but there was a failure to recognize the sleep apnea as the cause. So the clinician, rather than addressing that, they kept giving them more and more medications with higher and higher doses. So sleep apnea needs to be recognized as a major factor in the development of systemic hypertension and in the occurrence of uncontrolled hypertension despite multiple medications. So, of course, the obesity doesn't help either, right? Obesity is also connected to systemic hypertension. Now, the systemic hypertension that occurs in obstructive sleep apnea patients is twofold. Number one, weight gain itself will cause systemic hypertension. And number two, the pathophysiological events that occur with the deoxygenation and the sleep fragmentation also in the long term cause, as a consequence, systemic hypertension. So, as you said, it is an area of clinical medicine that is often overlooked, and we need to always, the takeaway message here is for clinicians, for patients and their families, if someone has uncontrolled high blood pressure and they have a history of snoring, they need to have a sleep study, polysomnography, to rule that out. And if they rule it in, to get that treated, because that would be the way to control the blood pressure. In addition to medications, they may or may not need more medications, but at least we cover our bases.
To wrap up our discussion, sleep apnea, as you mentioned, is often under-recognized in the medical community. And what final remarks would you like to share with the general public regarding the importance of sleep medicine?
Very good. The major obstacle in terms of in the area of sleep medicine is this: people are asleep when these things happen, so they don't recognize it. Okay, and not always do people have bed partners that would tell them, hey, you're snoring or you stop breathing when you sleep. Even when people are told that, hey, you stop breathing, they don't really take it seriously because they're not aware of it. They're not aware of it. They don't see it. They don't hear it. They don't experience it. They don't feel it. So they may undermine the condition that they have. So we need to raise awareness from the perspective of this. Okay, number one, when you wake up in the morning, do you feel refreshed? Do you hit the ground running? Have you had a good night's sleep? During the day, are you fatigued? After lunch, do you feel terribly sleepy? Do you wake up in the middle of the night choking or gasping for air? Are you gaining weight? Inexplicable weight gain. Why are you gaining weight? Or are you having morning headaches? So we need to be cognizant of the fact that we go through things during sleep and we don't know it, so we need to be aware of it. And the way to be aware of it is one simple question we ask ourselves: do you feel refreshed when you wake up? And do you feel well during the day? Do you feel fatigued or not? Those are the simple questions that we can ask, so that we become cognizant of the fact that we need to monitor ourselves without monitoring ourselves indirectly through the way we feel during the day. And if we don't feel well during the day, we need to look at our sleep and ask ourselves questions. For instance, I had a patient about 4 months ago. He literally came in. He lives by himself. He's a professional, and he recorded. He had a smartphone. He basically recorded himself all night. Just put the recording button, and he slept. And he had terrible sleep apnea. And the reason why he did that is because he just didn't feel well during the day. And he asked himself, maybe I'm not sleeping well. What is going on during my sleep? And so we successfully diagnosed him and placed him on good treatment, and he's doing well today. So let us be aware of the fact that things can happen in our body during our sleep. And if we don't feel well when we wake up, we need to delve into the possibilities of things that are occurring during sleep that we can very simply address to minimize long-term consequences.
Thank you very much for your time. It's a very informative interview, and I'm very happy to have you today.
It is my pleasure, Naomi, and I wish you well. If there are any follow-up questions, please email, and or we can do a second phase. I'm here. I'm dedicated to this cause, and thank you for having me, and thank you for giving me the platform to educate the public.
That wraps up this episode of Diet, Disease, and Doctor Dialogues. Thank you for tuning in with me today. In this interview episode, we looked into sleep apnea, an often overlooked and very serious condition that has major weight and cardiovascular repercussions. I hope this has built your sleep apnea awareness to help identify the condition in yourself or loved ones. But before I say goodbye, don't forget to subscribe. Your support means everything to me. So stay curious, stay safe, and until next time, this is Naomi Faleka, signing off from Diet, Disease, and Doctor Dialogues. See you soon!